fixation, the rotational stability because of the broad flat shape, and because it is collarless, it allows full seating in a prepared canal. The type 2 stem is basically a double wedge or a metaphyseal filling stem. It is wider in the anterior-posterior plane as compared to a type 1 stem, and the preparation for this stem is reaming followed by broaching as well. So if you compare, this is the canal, if you compare a type 1, it's a flat wedge, and in a type 2, you get increasing diameter in the anterior-posterior plane as well. So it fills the metaphysis in a much better fashion. Type 3 has a consistent taper. There is no abrupt change in geometry and has been further divided into A, B, and C. Type 3A is a tapered, rounded conical. I think Dr. Pachore has probably the massive experience with utilizing this type of an implant. Some have proximal fins for rotational stability, like the bicontact stem, and the stability is by 3-point fixation. And again, reaming and broaching is required. Type 3B is what we know as a conical taper, like a Wagner redapt stem. Version is independent and one of the best stems in my hands for primary and revisions. If you see, this patient has massive fractures with ankylosed hips with some extra-articular ankylosis. Here you wanted to adjust the version independently, and he was 18 or 19, so we've decided to use an uncemented short conical Wagner type of a stem. It is also my go-to stem whenever an intertrochanteric fracture presents to me. That is very rare. I would rather go for an uncemented stem, repair the abductors and the lesser trochanter because they are all in continuity with fibrous tissue and they do exceedingly well. 3C is the rectangular or a Zweimolar design. I have never used it. Very popular in Europe and also has been used previously, I think, in India at certain centers. Type 4 is a cylindrical design, which is similar to what we call as either an echelon stem or a solution stem, has a collar, completely engages the diaphysis. The indications are mainly in revision, or you could also consider using it in a situation like an intertrochanteric fracture. Type 5 is a modular stem, which is like an SROM stem or a modular Wagner type of stem. And I like to use them in complex primaries. These are excision arthroplasties done several years ago. You can do a femoral shortening osteotomy, park the sleeve. Especially you can use it, the distal diameter of the stem is 6 millimeter. So in a diaphyseal patient in whom the diaphysis is actually not developed, you can consider using that stem. And also in DDH, where you have to consider femoral shortening osteotomy. So very versatile stem. Type 6, I have never used it. It's a board stem, anatomic stem, and I don't know whether it was ever made available. We will ask Dr. Pachore in the end because it was not available since I have been practicing. A cemented stem, obviously, is two philosophies, taper slip or composite beam. I'm not going to go into details of that, but it's probably the most, so all the indications that we have considered till now can covered by one design, and that is a cemented stem implant. So I think the message, or if anything I want to take away myself from this talk is, although there are varieties of uncemented stems, you need to choose uncemented stem depending upon the geometry and the door classification, but the cemented stem remains a gold standard and it probably is utilized in all kinds of geometries that are available to us. Thank you.